Hello, everybody. Good evening. A warm welcome to IAB's online thoracoscopy certification course. This is the fifth module of a very, very successful, very, very popular, very, very interesting and educative webinar series. And we are very, very happy that each module has met with an excellent response, and we have crossed more than 1700 logins each and every time. Today's module is going to be extremely interesting because we actually have a galaxy of stars. Each of them are just so amazing in their knowledge of thoracoscopy. Each of them are fantastic teachers and they do fantastic work. So with this small introduction, I want to start with the webinar. I would like to first introduce the captain of the ship, Dr. Rajadhar. I'd like to introduce him. So honestly speaking, Dr. Rajadhar requires no introduction whatsoever, but I'm just completing the formality. So Dr. Rajadhar, he is the Joint Secretary of Indian Association for Bronchology. He is the Secretary of Indian Chest Society. He is a consultant chest physician at C.K. Birla Hospital, Kolkata. He is the proud recipient of Dronacharya Teaching Award. So, we have the best person teaching us. And hundreds of publications and just so much to talk about him. And most importantly, he's a very, very dear friend of mine. And so we are lucky that we have Dr. Rajadhar moderating the session. Over to you, Raja.
Thank you very much, Abita, and kudos to you for having come up with this thoracoscopy module. We are doing the fifth version of this module today, and we've had wonderful response from throughout the country. Applause have poured in, and it's a lot of effort put in by you and lots of youngsters in Mumbai, Mehul, etc. A lot of people have put in a lot of effort to put this course together. So I'm extremely pleased to be a part of this module today. And we have a very elite galaxy of stars, youngsters, who are with us today to talk to you on various aspects of thoracoscopy. The first person that I'm going to introduce is Dr. Bala Thadikonda. He's a consultant interventional pulmonologist working in Visakhapatnam. So I've known Bala for a long time, and I have always admired his passion for interventional pulmonology, and not just interventions, for pulmonology in general. So I think I saw Bala for the first time about 7 or 8 years ago, and I was stuck with about the passion with which he did interventions, pediatric, adult, and he's going to speak about a particular space in intervention about thoracoscopy. And I hope we spend a wonderful 20 minutes listening to Bala's talk. Bala, welcome to the platform, and over to you.
Good evening, all. So first of all, I would like to thank Amita madam and Raja sir for giving me an opportunity to talk here. So I'm going to share my screen. Can you see my screen?
Absolutely, Bala. Yes. Just put it on full screen for us.
Yes. Good evening all again. So in the next 20 minutes or so first of all, greetings from Visakhapatnam. I come from this coastal city. So in the next 20 minutes or so, we're going to touch upon a few aspects of thoracoscopy and its role in malignant pleural effusion. So we're going to start with the definition of medical thoracoscopy, its indications, contraindications, complications. So what are the types of thoracoscopes, and how does the normal and abnormal pleura looks on a thoracoscopic image? So what is a malignant pleural effusion, its definition, role of thoracoscopy in malignant pleural effusion, different thoracoscopic findings in malignant pleural effusion, and we're going to touch upon what are the different methods of doing a parietal pleural biopsies with forceps, cryo. So this is what we're going to do in another 20 minutes. So starting with the definition of thoracoscopy, it is defined as examination of pleural space in a non-intubated patient under conscious sedation. So what does it mean? In minor sedation, you can pass your thoracoscope inside the pleural space and examine the pleural cavity, where then you can take pleural biopsies under direct vision. At the same time, you can do drainage of pleural fluid and also pleurodesis in the same sitting. So this is what in general what is a medical thoracoscopy. So it is very, very good in diagnosing exudative pleural effusions, more than 90% sensitivity. So what are its indications? The gold standard indications for thoracoscopy is an undiagnosed pleural effusion of any matter. That is the most commonest indication. And you have other indications if you are doing a thoracoscopic lung biopsy in diffuse parenchymal lung disease, that is an ILD. Obviously, it is not for starters. So this can be done, but you need to have good experience when you are doing a thoracoscopic lung biopsy. So I would say that this is not the correct indication. I would say that, okay, for undiagnosed pleural effusion, undiagnosed exudative pleural effusion, that is a gold standard indication. And also it can be done in the staging of lung cancer and in malignant mesothelioma, where you can do biopsy and staging. And also in the primary spontaneous pneumothorax, where you can demonstrate bulle or blebs on the visceral pleura. So what is an absolute contraindication? It is lack of pleural space. Again, it can be because of extensive thick adhesions, pleural fibrosis, and previous pleuritis. So that's an absolute contraindication. So what are the relative contraindications? So relative contraindications, that can be poor general health, hypoxemia or hypercarbia because of massive pleural effusion or a tension pneumothorax, where the patient can't lie down in a lateral decubitus position, where he can't sustain that position. And if you're not able to collapse the lung when there is severe hypoxemia, anxiety, pain, so these are relative contraindications. Obviously, you can get over it when you take adequate precautions. So another relative contraindications are coagulopathy, renal failure, hepatic disorders, recent myocardial infarction, or a patient is on antiplatelets and anticoagulants. These are all relative contraindications. So these can be corrected and you can perform a thoracoscopy. So what are its complications? Basically, it is a very, very safe procedure. Complications are very, very minimal. And most of the complications are primarily because of anesthesia or sedation related, like hypotension, hypoxemia, respiratory arrest, and arrhythmias. Most of them are sedation or anesthesia related. So coming to the procedure related complications, they are very, very minor. They can be around 2 to 6%. There can be a persistent air leak when you are doing adherolysis, when you are inadvertently targeted the lung, when you're doing a biopsy. So there can be a persistent air leak, usually for a couple of days, and it can subside by itself. And there can be a subcutaneous emphysema, fever, hemorrhage, and a wound site infections. So these are procedure-related complications. So what are the rare complications like air embolism, re-expansion pulmonary edema? If you don't give enough time for the air to re-enter when you're removing the fluid from the thoracic cavity, so there can be chance of re-expansion pulmonary edema. And also rare complications like tumor sitting at the port of entry, and death is reported in thoracoscopy, but it is extremely rare. So what are the different types of thoracoscopes? So there are basically two types of thoracoscope. We have already seen this before, a semi-rigid and a rigid thoracoscope. So where does it differ? As the name says, semi-rigid, the proximal part of the thoracoscope is rigid and the distal part is flexible. It looks just like our bronchoscope. It has a working channel. It has a hand grip and a suction. So if you are well versed with your regular bronchoscopy, thoracoscopy is semi-rigid thoracoscopy is not at all an issue at all. The only difference is the distal part is flexible, and you have a working channel where you can pass a biopsy process. The rigid thoracoscope, as the name says, the whole the whole instrument is rigid, and you have a big working channel, and you obviously you have a rigid biopsy forceps. So that is the difference between a semi-rigid and rigid. So coming to the different types of rigid thoracoscopes, so you have a Storz 11 thoracoscope, you have a Storz 6 thoracoscope, and you have a Wolf 7 thoracoscope. The design of all this thoracoscope is almost all the same. There is hardly any difference between these designs. Everything has a working channel, and you have an optical forceps and a biopsy forceps where you can perform adhesiolysis, parietal pleural biopsies, and so. So coming to the semi-rigid thoracoscope, so we have seen this before. It's look like a normal bronchoscope with a proximal rigid part and a distal flexible part. So and you can have a dedicated biopsy forceps with it. It has a 2.8 working channel where you need to pass a larger biopsy forceps, not your regular bronchoscopic biopsy forceps, not the 1.8 biopsy forceps. You need to pass the larger biopsy forceps, that is the 2.4 biopsy forceps, where you can get a better yield of the parietal pleura. So This is what I say. This is the major difference when you are doing a semi-rigid and a rigid thoracoscopy. So once you introduce your thoracoscope, whether it is a semi-rigid or a rigid thoracoscope, so if you want to do biopsy at the lateral part of the lung, that means this part of the lung. So if you want to do in a semi-rigid, you just have to do an up angle and flex the distal part of the thoracoscope, and you can easily pass your biopsy forceps and get the biopsy from this part. That's the lateral part of the lung. Whereas if you want to do a biopsy at this part of parietal pleura, in the lateral part of parietal pleura with a rigid thoracoscope, you need to bend the rigid thoracoscope. There can be strain over the neural structures and the vascular structures, and there can be angulation at this rib level where that can cause pain during procedure. So that's the difference if you are performing a semi-rigid and a rigid thoracoscope. So in semi-rigid thoracoscope, it is maneuvering is easy. There is hardly any pain while doing the thoracoscopy. And another major difference, this is what is the major of the major difference, is the size of the biopsy forceps we use. The normal size of the biopsy forceps in a regular semi-rigid thoracoscope is 2.4. So this is how it looks. Whereas in a rigid thoracoscope, you can pass a 5 mm biopsy forceps. The cup, the dia is more than 10 mm. The more than 10 mm, where you can have a very large chunks of tissue. So these are the two main differences when you are doing a thoracoscope of a semi-rigid or a rigid. So coming to the malignant pleural effusion. So malignant pleural effusion is defined as infiltration of cancer cells in the parietal pleura. This can be either demonstrated either by a parietal pleural biopsy or a fluid cytology positive. So that is the definition of malignant pleural effusion. So in majority of the cancers, around 15% of all the cancers can develop malignant pleural effusions, predominantly being lung and breast cancer. That accounts for around 50 to 65% of malignant pleural effusion. And also, it can be also seen in mesotheliomas, metastatic cancers from the stomach and ovary, lymphomas, and other hematologic malignancies. So, if you come to the role of thoracoscopy in malignant pleural effusion, as the name says, primary aim of thoracoscopy is to obtain a specific diagnosis for undiagnosed pleural effusion. This is the cornerstone used if you want to do a thoracoscopy for malignant pleural effusion. So once you do a thoracoscopy for malignant pleural effusion, there can be different findings you can see on the parietal pleura. There can be pleural nodules, hyperemia, pleural adhesions, pleural plaques, ulcers. We want to come to it in shortly. How do they look in the thoracoscopic image? So at the same sitting, if you are doing the thoracoscopy for malignant pleural effusion, you can at the same time you can do thoracentesis, adhesiolysis, where you can break the adhesions and you can create one single cavity and let the lung expand in that cavity, where that is a good sign if you're doing a pleurodesis. You can do IQC insertion during thoracoscopy, and also you can do talc poudrage. So we're going to come to this later. Vishweshwaran is going to speak on this. So how does a normal pleura look on thoracoscope? This is how a normal pleura looks. So thin, shining, light, whitish. You can see your blood vessels properly, and you have this fat seen on the rib surfaces. So this is how a normal parietal pleura looks. So these are the images of abnormal pleura. These are dull, unhealthy pleura, usually seen in chronic pleuritis, where you can see there is loss of shine and you hardly see any blood vessels, and it is edematous. So it is usually seen in chronic pleuritis. And another finding usually seen in the malignancy are white fibrinous pleura. So this fibrous pleura is very, very difficult to do biopsies, especially if you are doing a semi-rigid thoracoscopy where your biopsy forceps is small. It is not so easy if you are doing a biopsy for a fibrous pleura, a semi-rigid forceps biopsy. Rigid thoracoscope won't have any problem where you have a larger biopsy forceps. You can easily strip away parietal pleura for a fibrous pleura. So just to demonstration, this is how a tubercular pleural effusion looks at, in thoracoscopic image. This is typical sanguine appearance seen in tuberculosis. As you can see, the pleural fluid is basically an exudative effusion with the ADA of low. Usually ADA is high, but if the ADA is low, please don't say that there is no tuberculosis. It is always better to do a thoracoscopy and get a tissue diagnosis and microbiological diagnosis for better treatment. So this is how a chronic pleuritis look. This is the case of CKD with persistent exudative pleural effusion and low-grade fever. So thoracoscopy was showing a chronic pleural inflammation with negative for all infections. This is how parietal pleural looks in CKD patients. This is how a normal malignancy looks in thoracoscopy. You get to see all different nodules on parietal pleura, ranging from small to large and also congregate to form masses and all. This is how large nodules or masses look on parietal pleura in malignant pleural effusion. And also in lymphoma, you can see this large edematous rough mucosa, and you can easily biopsy this with semi-rigid thoracoscope. In mesothelioma, the findings differ from epithelioid, sarcoid, or biphasic, starting from few white nodules to normal plaques to thick fibrous pleura, where it is very, very difficult to do biopsy with semi-rigid thoracoscope, where rigid favors more because it is a larger biopsy forceps. Sometimes you need to search for the nodules. This is the case of low ADA exudative pleural effusion. So where you can see unhealthy lung and also this white pleural plaques. And you look properly, especially in the costophrenic angle or on the diaphragmatic pleura, you get to see this nodules. And this is the most commonest site to get malignant pleural nodules or malignancy in malignant pleural effusion. So you need to assess the pleural cavity properly, thoroughly, right from apex, the lateral surface, medial surface, diaphragmatic pleura, and everything, so that you can have a better biopsy, better visualization. So coming to the different types of parietal pleural biopsies, so this is what is called as a pinch biopsy. So when you do pinch biopsy, when you have a smooth nodules like this, it is very easy to just go and bite the nodule and get a biopsy. So this is called as a pinch biopsy. Obviously, you want to use a larger biopsy forceps, not the 1.8 mm. Please note, it should be a 2.4 mm biopsy forceps where you get a good amount of tissue. The classical method, what we teach is it's called the strip and peel method biopsy. So the only difference is once you catch the pleura, you need to do a lateral movement of the biopsy forceps so that you can strip the parietal pleura. So this is called a strip and peel method while doing thoracoscopic pleural biopsy. So this can be easily done in thin parietal pleural lesions or plaques. It is very difficult if you are doing on a fibrous pleura. So another method, if you want to do a biopsy on a fibrous pleura, there is one dedicated instrument called Olympus IT knife. This is basically a coagulation probe with an insulated tip. So this is the coagulation part, and this is the insulated tip. This is just a normal probe. So where you can pass inside the working channel of the bronchoscope. So basically, you need to create a hole. Just coagulate the surface with a hot biopsy forceps. Then you pass the IT knife and you go inside the submucosa and you do a circular cutting of the parietal pleura. So you can get a good biopsy. But the only disadvantage is it is expensive and it is not easily available. It's almost cost 30,000 per instrument, and it is not easily available. For us, 30,000 is very, very huge. You can just do a rigid thoracoscopy and just get a biopsy with no amount of money. So another method, if you are doing, if you're not able to get big biopsies with your regular biopsy forceps, you can as well pass your regular cryo probe, what we use it for transbronchial cryolung biopsies. The same probe can be passed inside the working channel of the semi-rigid thoracoscope, and you just have to go at the lesion, probably the masses or the pleural surface, and you just freeze the surface and strip over. So usually you get a very large amount of chunks and you're doing a cryopleural biopsy. So if you're doing a semi-rigid thoracoscopy and if you're not able to get good biopsies with your regular biopsy forceps, you can just switch over to cryopleural biopsy to get good biopsies. So what is the diagnostic accuracy of thoracoscopy, especially semi-rigid thoracoscopy, the meta-analysis by PGI Chandigarh, Dr. Ritesh Agarwal. So semi-rigid thoracoscopy is a good sensitivity, more than 90%, and excellent specificity. So the advantage is this. So the need of analgesia and sedation is less, primarily because the instruments are flexible. The trocar is flexible, the scope is flexible. there is no compression of the underlying neural structures, so it is easily can be maneuvered. So that's the take-home message from this paper. And it is difficult to obtain tissue from fibrous pleura. So that is the two major points from this meta-analysis. This is from PGI Chandigarh. So coming to the difference between a rigid and a semi-rigid thoracoscope. So one is from PGI Chandigarh and another is from Slovenia, Alice Kaufman. So both of them say the same thing. The diagnostic accuracy is comparable to these, but the only difference is rigid thoracoscopy is found to be superior because you get a larger biopsy pieces. So coming to the difference between cryo and forceps biopsy, again, this is from PGI Chandigarh. So what they've seen is the diagnostic yield is almost the same as a forceps. But if you combine, the diagnostic yield increases. The cryoprobe yielded pleural tissue specimens that are significantly larger. Obviously, it will be larger because you will have a large amount of tissue. So because when you're getting a large amount of tissue, it can be easily pick up many rare cases like melanomas, lymphomas, IG-related pleuritis or nephrocalcinosis. It can be easily picked up by cryoparietal pleural biopsies. So to conclude, thoracoscopy is a simple, effective tool for diagnosing exudative pleural effusion. It is the best investigation for malignant pleural effusion. The diagnostic yield of semi-rigid is comparable to the rigid. It is an OP procedure with minimal sedation required. You can do pleural biopsy, drainage of fluid, pleurodesis at the same sitting. And if your pleural biopsy is failed with forceps, with the same instrument, you can pass a cryoprobe and do a cryobiopsy before switching over to a rigid. Thanks for your patient listening.
Thank you very much, Balaraju. I think that was absolutely brilliant, lucid, very strong carry-home messages. I loved your videos. I really liked the way you put things together and had a flow, and it was simple for everyone to understand. I hope the 1900 odd delegates who are actually logged in today had a field time, loved what they listened to. I'm sure they did. So we'll go on to the second talk now, and we'll move over to Dr. Vishweshwaran. Dr. Vishweshwaran is a consultant interventional pulmonologist and sleep medicine specialist from Yashoda Hospitals in Hyderabad. Now, Vishwesh and I go back a long way. I've actually seen him grow up. I have done quizzes with him when he was doing his DM. I have seen him win quizzes with alacrity on a regular basis. I have known him as someone who loves to publish. He's an academic. And then he's grown his interventional skills. He is a very skilled interventional pulmonologist who's done a fellowship in interventional pulmonology. And he is now a mentor of sorts for all the young interventional pulmonologists in the country. So over to you, Vishwesh. I'm looking forward to your talk. I'm sure you will have wonderful carry-home messages for all our audience.
Thank you, Dr.
Over to you,
Raja.
Vishwesh.
Thank you, Dr. Rajadas sir and Amitanane ma'am for giving this opportunity. So after a very exciting talk by Dr. Balaraju sir about the medical thoracoscopy, now we'll move on to the bread and butter of the pleura, that is the pleurodesis. So this will be the agenda for the talk today. So basically, what is pleurodesis? It is an induction of symphysis of the visceral and the parietal pleura by introducing an agent to stimulate an exuberant inflammatory response. So the primary objective of any pleurodesis is to obliterate the pleural space by creating the adhesions between the lung and the chest wall so that you prevent the accumulation of the air or fluid. So there are multiple ways of doing the pleurodesis. It can be a chemical agent, or it can be during the time of a thoracoscopy, you can do a pleurodesis. Or the recent one which has come in the scene is the role of the indwelling pleural catheter. So there are certain terms which we need to understand how we evaluate the success of a pleurodesis. So a successful pleurodesis is a one where post-pleurodesis there is no significant recurrence of fluid on chest radiograph, and there should be a lack of repeated pleural intervention like a repeated tap at 3 months, and less than 50 ml fluid should be drained by the IPC on 3 separate occasions without significant effusion on X-ray. Then if all these criteria are met, we refer them to as a successful pleurodesis. And we call the pleurodesis as a complete response if there is no fluid reaccumulation within the 30 days. And we call it as a partial response if there is a fluid occurrence on chest X-ray. However, it is not significant enough to cause a dyspnea, so no further pleural intervention is required. And we will call it as a failed pleurodesis when the pleural effusion persists without palliation of the patient's symptoms. So as we saw earlier, pleurodesis can be chemical pleurodesis or a thoracoscopic intervention or an IPC. So amongst chemical pleurodesis, we have got a lot of agents which can be used to induce the pleurodesis. Of these, the most common ones which are used are the tetracyclines, which may be in the form of a doxycycline or a minocycline or a tigecycline, or people have even tried quinacrine. But in India, most of the cases we use the tetracycline or the doxycycline form of pleurodesis. Or sometimes you can use a cytotoxic agent. For example, bleomycin is extensively studied as a pleurodesis agent amongst all the cytotoxic drugs, but mitomycin C or metoxantrone or carboplatin has also been tried in clinical studies. And with respect to the bacterial agents, though not commonly followed in India, Corynebacterium parvum, OK432 or Staphylococcal superantigen or even lipotecoic acids has been tried as pleurodesis agent. But one most important thing which is considered to be the gold standard of all the chemical forms of pleurodesis is the talc pleurodesis. And if you see, even in India, of late, we have access to a good quality talc. So therefore, the talc pleurodesis is gaining predominance over these tetracyclines and doxycyclines, except for resource limiting conditions. And this success rate of the talc pleurodesis is somewhere between 68 to 97%. Apart from this, one another agent which is commonly used as a pleurodesis agent in India is the povidone iodine, and it is generally used as a 100 ml of 2% povidone iodine solution. But however, one another simplest form of the pleurodesis which does not require an external agent is the blood patch technique, where 50 to 100 ml of an autologous blood is transfused, and this is generally used for cases of pneumothorax where you want to close the patch and cause a pleurodesis. Apart from this, silver nitrate has also been tried. But for all practical purposes in India, we use the talc pleurodesis, we use the tetracycline pleurodesis, the povidone iodine, and the blood patch. So the choice of the agent will depend upon the local expertise, the availability of the individual agents, and the underlying process for which the pleurodesis is considered. And generally, most of these chemical pleurodesis are introduced via a chest tube. The patient has a chest tube and you introduce it into it, and the chest tube size can vary between 24 French or even a small pigtail catheter like a 12 French can also be used for doing the pleurodesis. So generally a patent intercostal drain with a three-way stopper is attached, and before doing a pleurodesis, you need to understand you need to give a 25 ml of a local, at least a 10 ml of a local lignocaine anesthesia before introducing the pleurodesis agent to anesthetize the pleural cavity. And you need to make sure pleura is a sterile space, and therefore you use a sterile glove. And 50 ml of sterile saline is also used to dilute this pleurodesis agent before it is introduced. And pre-medication with analgesics is also needed because post-pleurodesis, the patient will have severe pain, and sometimes this pain can cause tachycardia and even may land your patient in a pulmonary edema. So of all the pleurodesis agent, the most commonly used agent worldwide is the talc pleurodesis. And we name it as two different things. That is a thoracoscopic talc powderage. As the name suggests, when you introduce the talc through your thoracoscope inside the pleural cavity, we call it as a talc powderage. But when you already have an ICD and you make the talc in the form of a slurry by mixing it with saline and then introduce into the pleural cavity, we call it as a talc slurry. But the most important thing, initially the concern was most of these talc can contain asbestos, but of late we are having talc which are free of these asbestos, and these are nothing but medical talc is nothing but the asbestos-free magnesium trisilicate. These are sterilized with dry heat, ethylene oxide or gamma irradiation, so that they are very safe and do not cause secondary infections if introduced in a sterile manner. There are multiple varieties of these talc pleurodesis. In US, you have somewhere between 11 to 20 microns, whereas in France, the particle size is somewhere around 34 microns. Previously, there was a belief that the talc pleurodesis causes an increased chance of ARDS because of the smaller size of the talc agents. But however, the European observation trial observed that there was no talc-related ARDS in 558 patients who received a graded talc. Therefore, of late, whatever pleurodesis which we are doing with talc, the risk of the developing ARDS is pretty low. And even in the Cochrane analysis, it is found that the talc pleurodesis is superior over the tetracycline, the bleocycline, the doxycycline, and and even the talc slurry for malignant pleural effusion. And both the BTS, ERS, and the American Thoracic Society recommend talc to be the agent of the choice, and use of the graded talc is encouraged, where less than 50% of the particles should measure less than 20 micron meter. And there is a very important trial, which is the TAPS trial, where they found that the thoracoscopic talc powderage, that is, you are introducing the talc in the form of a powder during a thoracoscopy, is found to did not have significant difference in the rate of pleurodesis failure at 90 days in comparison to the talc slurry, which means you can do the pleurodesis with the talc in the form of a powder during the time of the thoracoscopy, or if you forget to do it, let's say that you want a diagnosis, after that you want to do a pleurodesis, then you can introduce the talc slurry through the ICD, and there is no significant difference in the rate of pleurodesis. So I'll just show you how we really perform the talc powderage for the delegates here. So as you can see from here, we are doing a thoracoscopy, and in this case, through the thoracoscope, you are able to see a nodular pleural growth. And there are multiple nodular pleural growths which are present here. And you can see the lung, which is moving with the respiration. And we are taking biopsy from the pleura with the help of these rigid thoracoscopic forceps. This is the protocol that we follow in our institute. So right now we are taking a big chunk of a pleura. And once this pleura is done, it is sent for a frozen section. And on table, the pathologist says whether you are dealing with a tuberculosis or a malignancy. In this case, it turned out to be an adenocarcinoma of the lung. So we know that we are dealing with a case of a metastatic pleural effusion. So here what we are doing is, through the thoracoscopy, we are introducing a tube. And as you can see from here, I am introducing the talc in the form of the powderage over the parietal pleura. The advantage of the talc powderage is that you can have a clear-cut vision where you are introducing the talc, and you can attain a uniform distribution of the talc, unlike what you do it in a talc slurry. And once the talc is introduced, now the patient has ICD is kept in place, and following that, we expect the pleurodesis to happen. But however, the most important thing is, how do you take care of your patient post-pleurodesis? The most important complaint all the patients of pleurodesis say is the pain. Therefore, analgesics should be given. However, initially there was a controversy that if you give an NSAIDs, it will control the inflammatory process, therefore will make your pleurodesis ineffective. However, recently off late, we are getting multiple data to suggest that this NSAIDs action on the inflammation is not that severe to cause a pleurodesis failure. But in our hospital, we use the opioids if possible to attain the analgesic release in the place of NSAIDs, because of a theoretical possibility of a pleurodesis failure by the control of inflammation by the NSAIDs. And the drain should be opened after 3 hours, and a chest X-ray should be taken after 24 hours to ensure that there is no pneumothorax or fluid collection. And if chest radiography is reasonable and there is no further fluid output, then the chest tube can be removed. Follow-up is advised after 4 to 6 weeks with a chest radiograph. One another important thing, once you do a pleurodesis, is always make sure that to follow up the patient, because if you have not done a pleurodesis under a sterile way, probably you are capable of introducing an infection inside the pleura, and this can form an empyema. But of late, the pleurodesis has been getting replaced by what we refer to as an indwelling pleural catheter in most of the settings, especially abroad. So this is nothing but a tunneled silicone tube which is introduced aseptically, and therefore there is a permanent access to the pleural space, and a negative suction tube is connected so that all the fluid is drained. So there are a lot of studies which has compared the indwelling pleural catheter versus the talc pleurodesis for malignant pleural effusion, and this is one of the important studies, which is the time 2 study. As you can see from the graph here, the dyspnea scores and the chest pain scores are little less for patients who are receiving the IPC in comparison to the talc. And therefore, this study said that among patients with a malignant pleural effusion and no previous pleurodesis, there was no significant difference between the IPC and talc pleurodesis at relieving patient-reported dyspnea. But however, the number of patients the severity of the dyspnea experienced by patients among the IPC is less in comparison to the talc pleurodesis. There are also other multiple studies, which is the CAL-GB study. This tried to understand which is the better modality for managing the malignant pleural effusion. And they found out that once an indwelling pleural catheter is used, the combined success outcome, that is consistent on reliable drainage and the lung expansion and the 30-day survival, was non-significantly higher in the tunneled catheter group in comparison to the TALC pleurodesis, which means that the indwelling pleural catheter can be a replacement for your TALC pleurodesis. And in addition to this, there are other studies which can try to compare the cost of the indwelling pleural catheter versus the TALC pleurodesis, but most of these are Western data. In India, cost really matter. However, in the Western data, it is found that there is no significant difference between the groups in terms of the cost of the initial intervention or adverse effects between the TALC pleurodesis and indwelling pleural catheter. And people have also tried to find out which one is better, whether it is a talc slurry pleurodesis or all the other agents, including the IPC. And they found out that IPC and talc slurry noted improved breathlessness in patients with IPC. So effectively, all these studies says that IPC is either non-inferior, or in certain cases, it can be superior to your talc pleurodesis. However, this is a very good systematic review and meta-analysis to identify the efficacy of the indwelling pleural catheter. So this study found out that there was no significant difference in the improvement in the breathlessness or quality of life between the groups of one group where talc pleurodesis was used and in another group where IPC was used. However, the number of the adverse events were greater in the IPC group and fewer in the IPC patients group, and fewer IPC patients required repeated pleural drainage. So there is also a lot of other studies which has compared between the role of the indwelling pleural catheter and the talc pleurodesis. And this is one study which I want to highlight, which is an ample study. And in the interest of this time, I'm skipping the data. And the conclusion of this study is that the treatment with an indwelling pleural catheter versus a talc pleurodesis resulted in fewer hospitalization days from treatment to death, but the magnitude of the difference is of uncertain importance, which effectively means we can still use talc pleurodesis in comparison to the IPC. However, the IPC has a slight edge over the talc pleurodesis in terms of the pain scores and the dyspnea scores. And in the interest of the time, I'm skipping few of these studies. And so what does the guideline really recommend? The guideline says that the talc pleurodesis is the first-line option in patients with malignant pleural effusions, and IPCs were recommended in patients with a prognosis of over 1 month in whom either talc pleurodesis was unsuccessful or in patients with an evidence of a significantly trapped lung. And even the ATS guidelines clearly says that the talc pleurodesis is a viable option, but in case if your lung has not expanded, like you have a trapped lung, then in such cases, putting an IPC is better over directly doing a pleurodesis, because it will help in minimizing the, help in improving the success of your pleurodesis. And IPCs are also indicated for patients. Even in this guideline, the IPCs are considered to be useful for patients with malignant pleural effusion with a non-expanded lung. However, this is something which is coming up, especially amongst the Western countries. So what they are trying to do is, apart from putting an indwelling pleural catheter, now they are trying to introduce the talc powderage through the indwelling pleural catheter to attain the pleurodesis. So they are putting the indwelling pleural catheter inside the indwelling pleural catheter. Now they are putting the pleurodesis agent so that the chances of a successful pleurodesis are significant. And even for mesothelioma, people are trying to understand the role of the indwelling pleural catheter. And in our experience, we have had patients with mesothelioma with a trapped lung where the indwelling pleural catheter performs significantly better in comparison to your chemical pleurodesis. To summarize, malignant pleural effusion is a marker of an advanced disease activity, and it is associated with a poor prognosis. And care should focus on palliating symptoms, reducing the hospital stay, and reducing pleural interventions. And in general, your indwelling pleural catheters offer a simple, effective method of managing malignant pleural effusion as an outpatient. And in certain studies, it is found that the IPCs are associated with a shorter duration of a hospital stay and a fewer ipsilateral pleural procedures. And IPCs are associated with an increase in the frequency of adverse events, especially in an untrained hand, in comparison to the talc pleurodesis. And when you put an IPC, you need to aggressively drain the fluid to attain an increased rate of pleurodesis. And this is what we are speaking currently, that instilling the talc via the IPC doubles the likelihood of pleurodesis. And it showed no and IPCs showed no significant difference in the dyspnea score in comparison to the talc pleurodesis. So I'd like to end the presentation here, and further questions we'll take it in the panel discussion. Thank you.
Thank you very much, Vishwesh. Lovely talk. I loved the way you went through the literature, sieved the literature, but then came up with messages, clinical messages, and your own experience was amalgamated into it. So, lovely talk. Thank you very much. And like you said, both for your talk and for Balaraju's talk, we'll try and pick up some of these topics and emphasize on certain areas that you spoke about during the course of the panel discussion. If I could have all my panelists switch their videos on, please. So I'll start off with the lady in the team. So I've got Dr. Devi Jyoti Dash, who is an associate professor SBIMS Raipur. Devi Jyoti is a very passionate young doctor, very determined. I know the determination with which she went through hardship and did her EDIRM, and I admire her for her passion for academics. She's got a lot of degrees to her name already at a young age. And I look forward to Devi's comments, opinions during the course of the panel. The second person, a great friend of mine, I've known him for a long time, Dr. Ashish Tandon. Ashish Bhai is a consultant chest specialist at the Haridaya Super Specialty Center in Prayagraj. Ashish has been doing interventional pulmonology. He's one of the first in the country to start off with EBUS. And I know he's got a dedicated interest in interventional pulmonology, thoracoscopy, and every bit of pulmonology. And last but not the least, we've got the young Dr. Pavan Kumar Biraris. So Pavan is a consultant pulmonologist at the Apollo Hospital in Navi Mumbai. Pavan again is very adept at interventions, at thoracoscopy, and every aspect of interventional pulmonology. I've heard him speaking at various meetings. And again, like the other people on the panel, is a sort of a mentor for the young pulmonologists that we have in the country today. So lots to look out for. There's, of course, Dr. Balaraju and Vishwesh, who will stay with us through the course of the panel. If you can unshare slides, please, tech team, and we'll start off. So the aim of the panel discussion today is to come up with some clear messages for all of the audience who are listening to us today. We have close to about 2,000 people today. So I'm hoping that all my faculty will keep their answers short and crisp. If there's anything that my panelists want to add to someone else's question, please put up your hand and we'll come to you. So we'll start off with you, Devi, and we'll start off with something basic. So the discussion today is mainly about malignant pleural effusion. And I wanted to know, in your clinical experience, in what you've seen around you, what are the common sources of malignant pleural effusion in our country? And we are talking malignant pleural effusion here. Devi.
Thank you so much, sir. So the most common sources are from the organs nearby. That is most common is lung cancer and breast cancer, and then comes the hematological malignancies like lymphomas. Further, genitourinary like ovarian cancer and GI carcinomas like pancreatic cancer also accounts for it. Mesothelioma is a rare, however, a very important cause for this. However, I also want to emphasize that about 7 to 15% of cases, the primary site cannot be diagnosed. So we have to search for that in every case.
Sure. So Devi, your order is lung cancer, adeno coming at the top. Then you said lymphoma. Then you spoke about secondaries and you spoke about various secondary sites. And then you came to undiagnosed pleural effusions, malignant but undiagnosed primary. So that's the order that you went at. If I can come to Dr. Ashish Tandon. Ashish, we cannot see you. I don't know whether there's anything wrong with the video or not, but at least I cannot.
There's something wrong with the video. I'll try to rejoin it, but okay.
So I'll just ask this question to you, Ashish Bhai, and then maybe you can rejoin. So basic tests to start off with. You see someone you suspect might have malignant pleural effusion. What are the tests, basic tests that you send off? And if you're sending fluid, how much of fluid do you think we should send off to the lab to try and isolate malignant cells? A message for the audience, please. Ashish.
So if we see the pleural fusion and we suspect that it may be a malignant pleural fusion, the first thing is we should do a thoracocentesis, and it should be preferably ultrasound guided, and choose the best location where to draw the sample, and the sample size should be minimum 40 to 70 ml. The latest paper shows that it should be 70 ml. Previously, it was between 40 to 60 ml. So 2023 says it should be 70 ml. So it can be between 40 to 70 ml, depends on the lab and on the expertise of the pathologist who is examining. And we should preferably send it in the proper vials, so that it should be examined by the pathologist, and fresh samples, if they can be taken up as fresh samples, then it would be fine. Otherwise, cell block can be prepared, and that would be good enough. Or if the liquid biopsy is available, then you can go in for that. Depends where we are practicing. The area I am practicing in, that can cater only the fluid which can be sent, and it can be examined freshly, or it can be sent for a liquid biopsy.
Sure. So wonderful, Ashish Bhai. So important messages. So what we are saying is send off a large volume of fluid. And when
Yeah.
we say large volume, we are talking somewhere between 40 to 70 ml, as Ashish said.
Yeah.
Thoracentesis, send the fluid off. So what other samples would you send? I mean, suppose you're doing the first pleural aspiration, Ashish Bhai. So we think it's malignant,
Yeah.
but there's other things that you would send off. So if we have a laundry list of things that you would send off along with the cytology for malignant cells, please.
Yes, it should be for looking for the whether it is exudative or transudative. So protein and sugar, ADA levels, and other cultures also, they are very
Sure.
important. So
Sure.
and the cytology count, what is
Yeah.
the predominant cell type
Yeah.
is there. So what routinely we are doing, plus it has to be for the malignant cells also.
Sure. And one of the things that has changed, and I think Bala spoke about this during his talk, is the fact that if you've done the first thoracentesis, and if you
Yeah.
don't have an answer, unlike
Yeah.
yesteryears when we would aspirate again, now you wouldn't do that.
Mhm.
You would go straight for a thoracoscopy as the next procedure. You
Thoracoscopy.
wouldn't waste
Yes.
time by doing another thoracentesis. Yeah, wonderful. So great messages. Let me get Pawan back into the discussion. Pawan, where would you place medical thoracoscopy in your diagnostic algorithm? And tell me cases, certain circumstances where you would avoid doing a thoracoscopy.
So absolutely, so as Dr. Bala has covered in his talk, when you have the pleural effusion of undetermined etiology, when your initial investigations, which we have enlisted now, like you have exudative lymphocytic effusion, but your cytology is negative and your pretest probability of diagnosis of a cancer is very high. Suppose you have a cytology positive, but there is not enough material for molecular markers. Like there is no material for ERPR receptor analysis, or in case of lung cancer, additional molecular markers required. That time, extra tissue is required and medical thoracoscopy comes in picture. You may have a recurrent pleural effusion, which is still on treatment, and you're getting, like somebody's on NTTB treatment empirically, on getting a recurrent pleural effusion, medical thoracoscopy, getting a tissue diagnosis becomes mandatory. And also it adds to the staging of a mesothelioma or lung cancer. Mesothelioma is somewhere the cytology is expected to be very low. In that situation, getting a tissue diagnosis becomes mandatory. And we look forward for the medical thoracoscopy in that situation. Coming to this question, which patients, like where should we avoid it? So these are the patients, like somebody is not able to tolerate the procedure. Like somebody is of a performance scale of 4, European ECOG performance scale of 4, not able to lie down for 30 minutes, or whose survival is expected to be less than a month. In that situation, we may avoid the procedure. Somebody who has unstable medical condition, like unstable cardiovascular status, bleeding diathesis which cannot be corrected, has a respiratory failure, or somebody who's having excruciating cough, not able to stabilize them. In that situation, we may avoid the medical thoracoscopy. And especially in malignancy, suppose you have done a PET scan and you have seen that the metastatic disease is there, you can get a tissue from supraclavicular lymph node, and pleural effusion proving whether malignant or not is not going to change patient's management. In that situation, I may not do a medical thoracoscopy or any pleural intervention.
Okay, wonderful. So you spoke about contraindications, you spoke about access to other tissue, which is more easily available and avoid a medical thoracoscopy. We can see you now. Great, Ashish, wonderful. Let me come to Vishwesh, and there's a couple of questions I'll ask you. One question in continuation to what I asked Pawan just now. So, Ashish Bhai spoke about doing a centrifuge on the pleural fluid sample and then forming a cell block. So my Western colleagues tell me that the cell block often gives you enough material to do even your mutation analysis. Whereas in our circumstances, we've always felt that we needed tissue. That's the issue. We needed more tissue to do all the tests, the immunohistochemistry, the mutation analysis, etc. So in your practice, do you think in the patients where there's a contraindication, which Pawan spoke about, we can do a cell block and get all the IHC and the mutation analysis done? Or do you think that's a challenge in our scenario? That was the first question I wanted to ask you, Vishwesh.
So generally, even at our center, whenever we do a tapping, we try to do a therapeutic tapping and send the maximum fluid for analysis. And many a times we have observed, except for mesothelioma, many a times we have observed that the pathologist was pretty confident in getting even a histopathological diagnosis with the cell block. And many a times they are able to put even this tissue for advanced molecular markers as well. So it is not it is not impossible to get a molecular marker if your tumor burden in the particular cell block is pretty good. But having said that, recently this was a thing which a discussion we had with Professor Munawar, who was also with does a lot of this pleural intervention. But surprisingly, his views were like they would still go for a pleural biopsy rather than going for a therapeutic pleural aspiration and sending the significant amount of fluid for cell block. But at our center, especially, and even for most of the centers in India where there is a resource constraint or an economic constraint, I would feel like doing a therapeutic pleural aspiration and sending for cell block would be more than sufficient to pick up most of these cases of malignant pleural effusion.
Yeah, so great message, Vishwesh. I don't know about most cases though. I mean, in my experience, when we have tried to create a cell block, we've had tissue which is enough in about 25 to 30% of the cases. I mean, maybe there's a variation between the pathologists that we have throughout the country, and we've ended up doing a thoracoscopy in most of the patients. I mean, that's probably because we have got access to the intervention and resources probably a lesser constraint, like you said, but we have ended up doing a thoracoscopy in a vast majority. The other question I wanted to ask you, and this has been covered by Balaraju already, flexible versus, so rigid versus semi-rigid thoracoscopy. If you can give the audience a message, where do you place each in your diagnostic algorithm?
So first of all, let me quote the advantages of your semi-rigid thoracoscopy. Basically, one, your learning curve is much easier, and patient comfort is much better with respect to the semi-rigid thoracoscopy. And your ability to scan across the pleural cavity, even going till the level of the apex and maneuvering will be a little easier when you're using a semi-rigid thoracoscopy. And there are certain demerits to semi-rigid thoracoscopy. One, the cost of the machine and the apparatus per se, and the wear and tear of the semi-rigid is quite high in comparison to your rigid thoracoscopy. And the biopsy material which you get are generally sufficient in most of the cases, but sometimes, especially when you deal with mesotheliomas, it might be little difficult to get a typical pleural P. And when it comes to the rigid thoracoscopy, the advantages are one, you can do a therapeutic intervention also. Let's say you see a lot of adhesions, you can break down a few of the adhesions which are not highly vascular. And second, you get to get a big chunk of pleural tissue because you use a broad-based rigid forceps. And so these two are the advantages, and the biggest advantages is the cost of the machine and the reusability. Like the wear and tear of the machine is pretty less when we use a rigid thoracoscopy. But the disadvantage of the rigid thoracoscopy is like you get a limited access to the pleural cavity, especially when you want to maneuver it to the apex. It becomes a lot more difficult, and it is generally very difficult to perform a rigid thoracoscopy in patients with conscious sedation because of the pain which they endure, especially when you maneuver it over the rib which you where you use the rib as a fulcrum to rotate your rigid thoracoscope. So that becomes a limiting factor. So I would, there is nothing, one is superior over the another when you use a semi-rigid or rigid thoracoscopy. But learning wise and early part of your career, you will be more easy to use a semi-rigid thoracoscopy because you are tuned. It is almost like using your bronchoscope, which you already have used in your as a part of your routine procedures. But over the period, what we have realized is considering the cost, considering the tissue which we get, uh, if you are confident, you can very well start using these rigid thoracoscopes. And especially when it comes to the rigid thoracoscope, off late, what we are doing is we are using the mini rigid thoracoscopes, which are not that big in diameter, like a 8 millimeter or a 10 millimeter. These are just like pretty small, and they can give a good amount of chunk, which is better than your flexi-rigid thoracoscope. So there is nothing to choose one over the another, but when you use, you need to understand your instrument and put them in the right place and do it.
Sure. So Vishwesh, great thoughts. If I want to summarize, there's a lot of people in the audience today who probably want to start off doing thoracoscopies. You know, there are people who are newbies, want to start off with the thoracoscopy, who probably know how to do diagnostic bronchoscopy. So if we give one message that if you're starting, and if cost is not a huge constraint, you're probably better off going with a semi-rigid to start with. And once you are used to the procedure, you can add in a rigid as an add-on for the procedures that you spoke about, where you want to take larger pieces, biopsies, so all of that at a later stage. If cost is a constraint, then of course you need to think about using the rigid and attaining proficiency with the rigid early rather than after it's semi-rigid. Is that fair to say, Vishwesh?
Yeah. That's the way it is.
Okay. All right. Let me come to Bala. So Bala, you've got someone who's coming in the morning. You've seen the patient in the outpatients. You've asked the patient to come and get admitted the next morning for a thoracoscopy. What are the boxes that you need to check? So what are the boxes? What are the pre-op, the pre-procedure ticks that need to be applied before you have the patient on the table and the patient is ready for a thoracoscopy?
So absolutely, there is no difference. The pre-op evaluation for a normal regular bronchoscopy and a thoracoscopy. There is absolutely no big difference. To summarize, you just have to see the cardiorespiratory status of the patient, and also you just to see a normal blood values. So I think to summarize, I think these two are the most important things. And I would look at it this: especially if you're dealing with a malignant pleural effusion, if you have a large amount of pleural fluid, so I straight away don't do a thoracoscopy on them. I usually do therapeutic thoracentesis one day before and post the case on the next day. The reason being, yes, you can do it on the same day. The only problem is the patient has to lie down on the lateral decubitus. Yeah. It is not so easy to have a 3 liters amount of pleural fluid in one side and to lie on the other side on the normal lung. It is very uncomfortable for the patient. That's what I feel. And the second possibility is the rare possibility of re-expansion pulmonary edema happening on the table, and you get panic because obviously you won't have an anesthetist all the time. So you're doing it as a daycare procedure and you're doing under conscious sedation. So you don't want to have any eventualities happening on the table. So you ideally prepare the patient, especially when you're having a massive pleural effusion. It gives you two things. One, the comfort to the patient. Two, you will get to know whether the lung is expanding or not. So if your lung is expanding, there is high chances that your thoracoscopy is going to be successful and your lung is expanding, and whatever you do next, the fluidolysis is going to be successful. So before that, you will get to know whether if your lung is not expanding, then you can plan your procedure. Whether you want to do a thoracoscopy or you want to do an IPC, and you can plan your procedure. That's what I look at it when I post a case for a thoracoscopy. And also, second thing I would like to look at is the level of adhesions inside the pleural cavity. So this is what I do. If there are a simple pleural effusion, no big adhesions, I straight away do a semi-rigid thoracoscopy. But if there are more and more adhesions and the pleural cavity, I usually take them for a rigid thoracoscopy. This is my own protocol. Sure. So this is what I follow, because the only problem, once you enter the pleural cavity with a semi-rigid thoracoscope, you need to convert it to a rigid thoracoscope when you have a larger adhesions and you're finding difficulty in removing all those adhesions to create one pleural space. So I think these two are the main important things. One is the amount of pleural fluid. I mean to say, other than the normal requisite of what you're doing in bronchoscopy or thoracoscopy. Yeah. One is the amount of pleural fluid. And second is the amount of loculations or adhesions inside the pleural cavity, where you can easily scan away with a regular ultrasound probe. You can get away with it.
Yeah, grand. So you spoke about bloods, Bala. So you spoke about checking the clotting profile. I guess you would also check platelets. Do you think it's important to look at the cardiac profile if it's not been checked? Do you need a 12-lead ECG and an echo as a compulsion before you put the patient on the table? Or would you take a call as per the patient in front of you?
So not in all the cases. A young chap who comes for a thoracoscopy for an undiagnosed pleural effusion, usually I don't do any ECG and all. Obviously, you will do the blood profile and the screening profile, your normal hemoglobin, platelets.
Sure.
Usually, ideally, I don't do. I usually reserve it to the people who are more than 50 years of age. You do an ECG, if necessary, history of diabetes, hypertension. Then you
Yeah.
ask screen for. Is there any possibility? Should you order for a cardiac consultation or treadmill cardiography?
Yeah. So Bala, all of us in this panel are sort of experienced interventionalist thoracoscopists. So I think for someone who's starting, and like you said, above the age of 50, I think it's a safe practice to at least get a 12-lead ECG and an echo done, and the basic bloods that you spoke about. The other question I'll quickly ask before we move over to the next question is, suppose your patient is on antiplatelets or anticoagulants. What do you do for these people?
Usually, this is what I do. The protocol says that you need to stop echosprin for at least 3 days and clopidogrel for at least 5 days. But this is the real world experience. Usually, you will not have a major issues even if you do on table. Because remember, you do a CABG on echosprin, antiplatelets, anticoagulation. You do a CABG, but here you are just doing a thoracoscopy. But the guideline says that you need to stop at least if it is an elective procedure. It is not an emergency procedure. If it is an elective procedure, you need to stop echosprin at least for 3 days and clopidogrel for at least 5 days before the procedure. Obviously, you will check the bleeding profile and the platelet count. So ideally, everybody feels that 50 to 60,000 should be the platelet count when you're doing a safely a thoracoscopic procedure. Usually, it is not a very, this doesn't cause many serious bleeding tendencies for a normal thoracoscopy, unless and until you have a very thick bands when you're doing a malignant pleural effusion, where you try to cut those bands where there is a large amount of blood vessels inside those bands. There can be a bleeding, but normal pleural biopsy, usually you don't bleed. As long as you stick on to the guidelines not to go and touch the rib spaces rather than hold the pleura on the rib, so you will not land up in any complications. The only thing in the thick pleural cases where fibrous, you don't know where is the rib and where is the
Sure.
in between the rib. So there is a possibility of damaging the vascular structure. But usually when you're doing a superficial pleural biopsy, especially, you will not have a major bleed happening.
Sure. No, very valid points, Bala. And again, sort of for the lay, like you said, for the people who are starting, you're probably better off stopping the aspirin for at least 24 to 48 hours, about 5 days for the clopidogrel. And I have known clopidogrel to probably be the most notorious agent as far as bleeding is concerned. You know, you have a ooze which goes on forever and it keeps bleeding. So clopidogrel. And if you're an anticoagulant, then you would want your INR in case of warfarin to be below 1.5 before you do the procedure. And for the NOACs, the newer anticoagulants, you would want that stopped for a period of 48 hours before you go on and do the procedure. So that's the broad outline, and important to be safe when you're starting, when you're building up your practice. It's better to be safe and not take risks as far as possible. Let me come to Devi. And Devi, we heard Balaraju speak about cryobiopsies. Vishwesh also mentioned it in passing. So what do you think about doing the conventional biopsies versus cryobiopsies? What is your practice and how do you position these various new modalities when someone starts off with doing thoracoscopies?
So, initially, while we are doing thoracoscopy, we can mostly use it for diagnosing, for tissue biopsy, and for adhesiolysis. These advanced techniques have a role where we have a highly vascular pleura to minimize the chances of bleeding, or we have a fibrous pleura, or in cases of mesothelioma where an invasion of adipose tissue or skeletal muscle is a must for the diagnosis. In those cases where we want to decrease the chances of bleeding, or we need to have a larger chunk, we may use these advanced techniques, but otherwise we can go with our normal thoracoscopic practices.
Okay. So I think one of the things that Bala said, which is relevant, is to combine both. So if you're doing a procedure and if you've got access to cryo, I think combining things probably makes a lot of sense. Taking a couple of cryo biopsies, taking your conventional biopsy forceps and taking tissue probably makes a lot of sense. But I don't think if you don't have access to cryo, it's not as if you're missing out on a lot of a diagnosis. I think all the studies that Vishwesh presented, Bala presented, were mostly done with conventional biopsies, and the yield was well over 90% in most cases. So you're not missing out if you're not having access to cryo. I'll come to you, Ashish Bhai. So, Ashish Bhai, we spoke at length about doing a pleurodesis. We heard Vishwesh speaking about the various agents. Now, suppose you don't have access to frozen section. He spoke about frozen section and then doing a pleurodesis at the same sitting. So what's your practice? Would you do pleurodesis at a later stage? Would you do pleurodesis at the same setting? And if you're doing it in the same sitting as a daycare procedure, what tells you whether this is a malignancy or not a malignancy before you do pleurodesis?
So, going about the medical thoracoscopy, you should have an idea when you are planning for it by the history, clinical examination, and all that. You have a fair idea where the ball is going to roll, whether it is maybe a malignancy, suspected malignancy, or maybe an infectious disease. And once you put your thoracoscope inside, you see if there is a lot of infection and adhesions and things like that, then you probably think that this is mostly a infection we are dealing with. Otherwise, if there is more cleaner thoracic cavity, or there is more of hemorrhagic fluid, or there is more of nodularity which is going on, then there is suspicion of a malignant lesion. The part of UP where I am practicing, we don't have any rose facility. So we take out biopsies, minimum 6 to 8 samples we take it out, and we put to the pathologist. And we wait for some time before putting into the chemical pleurodesis like the talc pleurodesis. So that is our routine procedure. That is the advantage is if the sample is not adequate, if the pathologist requires that there may be something or overlap of the diagnosis, then we can think of other probabilities also. But if we put it in the same setting, then definitely you should have ROSE facility, because it will be able to tell you whether the sample is sufficient and whether we are dealing with the infective or an malignant lesion. You will have some idea. So if you have ROSE, you can put directly the talc powderage. You can visualize the pleural cavity, and you can put the talc. That is the best practice. But if we don't have those facilities, still we can do it, and at a later time we can put in the talc slurry through the same tube which we have put in for the medical thoracoscopy.
Yeah, so very clear message, Ashish Bhai. If you have access to a frozen section, and like Vishwesh, we too have access to frozen section. So if you have frozen section, doing it as a daycare procedure and doing a talc poudrage at the time, it serves you well, and you can probably discharge the patient the same day or the next morning. However, if you don't, like you said, you would wait for the fluid to be drained out completely. You would wait for the drainage to be below 150 ml before you put the talc slurry in for pleurodesis. So that's, I think, a very clear message from you. Let me come to you, Pawan. Pawan, this access to frozen section, I don't think there's a lot of centers in the country which have access to frozen section. And a lot of the audience here listening to us today, even if they've started doing thoracoscopies, won't have this luxury. The world, I understand, is going towards thoracoscopy as a daycare procedure with pleurodesis done at the same sitting. So what are your thoughts about how important getting a frozen section is in centers which have significant volumes of thoracoscopies, pleural effusions, which need diagnosis?
Absolutely, sir. I agree with you because I work at Tata and I work at Apollo. Tata, I have the access to the frozen, but in Apollo, I don't have immediately near the endoscopy. So having a frozen definitely has an advantage that it will give you rapid diagnosis. It will reduce the number of biopsies taken, and it will reduce the duration of the procedure as well. And it will help you to triage the sample to be sent, maximum sample to be sent for histopathology, the sample to be sent for microbiology, for gene expert, and the TB culture as well. So definitely getting a frozen, especially you are dealing with mesothelioma, well, getting a superficial biopsy, because the tissue has more invasion in the deeper layers. So you need to have a deeper biopsies. In that situation, frozen definitely, or in fact, imprint cytology, which has been practiced with few centers, is been very useful. So if you ask me, it has a good potential for rapid fluorodesis pathway. So when the malignancy suspicion is very high, when you are proven the malignancy, it's easier. The cost constraint becomes less, the hospital stay becomes less. So definitely frozen adds to the diagnosis. But yes, it is, as Dr. Ashish has said, it's not mandatory. You can do a delayed fluorodesis with the help of a talc slurry on a later date through the same tube which you have put during thoracoscopy.
Sure. So for large volume centers out in the audience, people who are listening to us, try and speak to your friendly pathologist and set up a frozen section, because that actually reduces the duration of hospital stay, saves money, the bed turnover rates are greater, and it probably makes sense to do that. Let's go to Bala for the next question. Bala, I wanted to, Vishwesh gave us a brilliant exposition of all the various agents for pleurodesis. If you can summarize what it is that you use in your clinical practice and what's greater efficacy, what do you find being well tolerated, less well tolerated? So maybe 2 or 3 agents and what you use in your clinical practice, Bala.
So just to summarize, we in our hand we have 2 agents. One is the talc, and second is the povidone. That's a betadine.
Sure.
10% betadine what we get in a 100 ml solution. The major difference is the cost, and both of them work wonderfully. Absolutely no issues at all. So almost the pain scores is almost the same as the talc and the betadine, but the only difference is the cost. The talc now comes at around 3,000 rupees, if I'm not wrong. The cost has been come down now, but before it was 7,000, 5 to 7,000 rupees it was before, and now it is around 3,000 rupees. But at the end of the day, betadine is just hardly 10% betadine bottle is just hardly 100 rupees. So you just take 20 ml of the betadine, 10% betadine, and mix it in just 50 ml of saline and put it inside. So obviously, Vishwesh has highlighted the role of analgesics prior to the talc, because this is what we usually follow. You infiltrate the parietal pleural space with the xylocaine before the procedure, so that especially I'm talking about a talc slurry or betadine fluorodesis. So the pain scores is almost the same, and the efficacy is almost the same. But what is difference is the cost. So this is what I practice in my place. So usually my inclination is towards the talc, because I have the access to the talc and the cost has now come down much. It's okay even if you do betadine, absolutely no problem. The only one case I had when I was doing a betadine fluorodesis in a COPD patient with a malignant pleural effusion, that fellow landed up in acute extubation. Luckily, I was doing it in an ICU setup. So immediately we could ventilate the patient and we could rescue him. So the only one case I had acute extubation of COPD immediately after installation betadine. So other than that, rest all the cases, there is hardly any difference. The pain scores is almost the same.
Yeah, great, Bala. So, I mean, I'll share my experience very briefly because it's slightly different to yours. And I think it varies according to the individual who's doing it. So, for me, the talc seems to be more effective than any other agent that I've used. So talc seems very effective to me. However, the pain that you have with talc to me seems slightly greater as compared to what you have with betadine. Betadine, most patients tolerate very comfortably. About 25 to 30% of my patients who are given talc complain a lot of pleuritic chest pain about 4 to 6 hours post procedure. So I have always thought that's because of the greater inflammatory inducing potential that talc has as compared to what betadine has. But I think for us also, it's between these 2 agents. Vishwesh spoke about the blood patch in a slightly different scenario. He spoke about it in the context of pneumothorax. So quickly coming to you, Vishwesh, a mention of the blood patch. I know it's probably outside the ambit of what we are speaking about today, but I think the audience would be interested, and I am for sure. How do you use the blood patch? When do you use the blood patch, Vishwesh?
So generally in our setup, we use the blood patch only for BPF. Like when there is a
Sure.
prolonged air leak, we use the blood patch. We generally don't use the blood patch as a pleurodesis agent for a malignant pleural
Sure.
effusion because of the risk of infection and even we don't know the efficacy of blood patch in a malignant pleural effusion. So what we do for a prolonged air leak is once the leak is not resolving, we take autologous blood patch. That means you take around 50 to 100 ml of blood from your median cubital vein, or sometimes if there is a femoral vein, we take it from that also. And then we keep the ICD vertically up, and we instill slowly through the ICD, and we make sure that the patient takes a deep breath so that it creates a negative intrathoracic pressure and sucks the blood inside that. And once the entire amount of the blood is instilled inside the pleural cavity, we flush it with a slight amount of saline, and we hold the tube vertically for some time so that it doesn't, the blood what we have instilled inside stays there at least till the clotting time is there, so that the blood doesn't come out of the ICD tube. And then we don't clamp it because if there is a pneumothorax, it is risk to clamp. So we keep it vertically up for some time, and then we allow it to drain. So, but to be very honest with you, my experience with the blood patch for even for a prolonged air leak is not that great. Most of these blood patch in our experiences have failed because you need to be very lucky for the blood to go exactly seal the particular part of the lung from which the leak is occurring. Though we had a successful thing in one or two cases, in most of the other cases it fails. Another important thing to note is when you do it, it should be perfectly sterile. So if you are not sterile and if you cause some infection, then blood becomes a very good medium for growth of bacteria, and it can cause an empyema. Another important contraindication is when you have a hydropneumothorax, never attempt a blood patch. That means it's already an infected pleural space. So when you use this blood patch, it should be for a sterile pleural cavity. So when you have an infected pleural cavity, never try to attempt a blood patch. So this has been the limited experience we have with blood patch.
And the tube doesn't get blocked by a clot, Vishwesh, when you're putting the blood in and holding it up. The blood does not
So
clot
you
off
have
into
to more than the tube, your syringe only sometimes will get clotted if you don't do it in a rapid success, in a quick way. So this problem we had, we will aspirate the blood. By the time you aspirate 50 ml of the blood almost starts to clot. So you need to be very quick enough to push it back into the chest tube, and that's why we flush it back with a saline so that the clot doesn't form.
Right. Grand. Very interesting. The next question I sort of stay with you, Vishwesh, is you're draining fluid. We spoke about daycare draining all the fluid. So is that a safe procedure, do you think? You're draining all the fluid away. Suppose you're draining 2 liters of fluid. Does that cause re-expansion pulmonary edema? Does that cause a lot of pain? Can the patient go into shock? Is some of the questions that people would want to ask.
So generally when we put an ICD, especially for a chronic pneumothorax, that is where the chances of the re-expansion pulmonary edema is significant. And when it comes to therapeutic drainage, also we limit not crossing more than 1 to 1.5 liters in a single go. We don't try to drain off the entire pleural cavity because of the risk of re-expansion pulmonary edema. So the moment we are tapping, if the patient says that he is having some sort of a chest discomfort, or he is saying that I'm experiencing some sort of a vague pain, that is the point probably the lung is expanding, and we try to limit our pleural fluid aspiration. And whenever such patient where we anticipate re-expansion, we keep them on oxygen because that is the primary treatment for this re-expansion pulmonary edema patients. So we limit our pleural fluid tapping not more than, at the maximum we have done was 1.5 liters, even though the patient does not have any symptom with the fear of risk of re-expansion pulmonary edema.
Sure. I mean, reading to the literature, speaking to people like Munawar, whom you spoke about, Vishwesh, they talk about equalization of pressures between the extra and the intrathoracic compartment, and the fact that there is hardly any risk of re-expansion pulmonary edema. So I'm asking you and the others on the platform, have you ever, during a thoracoscopy, ever come across a patient who's developed re-expansion pulmonary edema?
So this in thoracoscopy, you don't get a re-expansion pulmonary edema because it's again you are equalizing the pressure by opening the pleural cavity. But when you are tapping it, there is still a risk of re-expansion.
Absolutely.
So
Correct.
in
Yeah.
thoracoscopy, yes, we have never seen a re-expansion from the edema happening.
Yeah. I'll come to you, Bala. So you have for sure. So go on, your story, Bala.
Yeah. So this was in not a malignant pleural effusion. This was an undiagnosed pleural effusion, short stature lady, obese lady. We are doing a thoracoscopy, and luckily on that day anesthetist was there. So there was hardly amount of fluid in the. It is not a massive pleural effusion. It is just a moderate pleural effusion. The moment we introduced the trocar and we tried to remove it, the whole lung just expanded. We didn't have any time. So the lung doesn't collapse. So even though it's supposed to collapse because the air enters, but the lung doesn't collapse. The lung just expanded. So that is not in your hand. So
Sure.
that you cannot determine whether the lung is going to expand fully or it should collapse when the air should enter.
Sure.
I had only one case on table where I had a re-expansion pulmonary edema. The patient went into respiratory arrest almost because we had to put the patient on supine position, intubate her, just put an ICD, just plaster it and just intubate her. We had a brief episode of hypoxia during that time, but obviously after some time we really didn't have any major issues. We had to ventilate the patient post-op. We just stopped the procedure. We could not do a biopsy because the moment we just put the trocar and we drain the fluid, the lung should be supposed to be collapsed, but it just expanded. We didn't have any control over it.
Yeah. No, I think what you said and what Vishwesh said makes a lot of sense. So audience, even though theoretically there seems to be a very low risk with thoracoscopy, I think there's prudence in not draining more than 1 to 1.5 liters at one go, because you will have that one exceptional patient whose lung will come up very suddenly, and you might have the risk of a re-expansion pulmonary edema. So that's a important take-home message for our audience today. Devi, I'll come to you. This is the question that we have discussed already to some extent, but to sort of put again bullet points against this. Complications of pleurodesis. What are the things that you keep in your mind, keep in your head when you go to pleurodese a patient? What are the complications that might occur?
So about complications of pleurodesis, how I divide it in my mind is there are some common complications according to the agent I use, and complication according to the procedure I'm using or the technique I'm using. So the common complications, as we all have talked about, is the pain. We have all seen the patients crying their lungs out. Next is fever, bleeding, and some rare complications like pulmonary embolism or re-expansile pulmonary edema, infection, etc. Now, according to the agent use, so there are a few cases of vision loss with povidone iodine being used. When we use talc, there is a chance of ARDS, especially in non-graded smaller particle talc when used because of the systemic absorption of the talc. Then comes according to the technique I am using. So if I'm using the sclerosing agent in an ICD, the complications of ICD can be there. Complications of thoracoscopy, like the complications of GA, atelectasis, wound infection, or when you are doing a talc pudraj, you can have pneumothorax, embolism, persistent air leak. All these can be a complication of pleurodesis.
Great, Devi. So important ones are pain, important ones are infection, and then you've got rarer ones that you need to think about, know about, because it might happen to that one exceptional patient where you're not expecting it. So you have to be prepared, but it's relatively safe. It's relatively safe to do a pleurodesis with the different agents that we discussed. I'll come to you, Pawan, with an interesting question. So you've got so of all the thoracoscopies you do, how many are there in which you end up doing both a bronchoscopy and a thoracoscopy at the same sitting? And what are the reasons? What are the indications where you would end up doing both? And if you had to do both, in your head, is there an order in which you would want to do them? As in, which one first, which one second?
So interesting question, Dr. Raja, because sir, it is a very uncommon clinical scenario. Like probably around 200 other thoracoscopies, I have done it once probably. And the reason being, like, once you have done a thoracoscopy, your lung is not expanding on table, and you feel there is no obvious pleural thickening which is explaining it. In that situation, we will look at the scans and see whether there is an endobronchial lesion or not. Suppose, and everybody will look at the films first before going for the scopy. But to rule out an occult endobronchial lesion, our patient had a mucus plug post-thoracoscopy where the lung was not expanding. In that situation, I required so mucus plug, blood clot, or any occult endobronchial lesion is probably a possible clinical scenario where I look at doing a bronchoscopy. Another situation we had is a case of a head and neck cancer who had post probably a disease-free interval of 2 years, came with a left-sided effusion and a right-sided lower lobe treel bed opacity, sputum negative. In that situation, we did a thoracoscopy and then followed by a bronchoscopy to rule out tuberculosis because it's an immunocompromised population as well. So these are the probably two common scenarios I can think of. Regarding the sequence, I would do the if there is no obvious endobronchial lesion on the high resolution scan, then I'd go for the thoracoscopy first, followed by the bronchoscopy. In such situation like where we rule out concomitant infection, then definitely thoracoscopy first, followed by a bronchoscopy, because when the lung is expanded well, the chances of hypoxia are less.
Yeah. So very important points that you made, Pawan. So I have maybe, I don't know, lucky or unlucky, probably done this in more than one case. So I have seen multiple ones. And you get given in your exam these chest x-rays where you have a large or a massive pleural effusion and there's no mediastinal shift to the other side. These are patients where you classically expect something endobronchially. I have to say that if I find someone with a large or a massive pleural effusion, I wouldn't probably go and do a CT because I would only see a lot of fluid on the affected side without actually managing to image the lung properly. So in those cases, I would probably do both and make sure that I don't have something endobronchially. And I would probably do the bronch first, make sure there's nothing endobronchial before I turn the patient around and then go and do a thoracoscopy. That's the sequence. But I don't think there's a right or wrong answer. It's important to think about this when you see that one exceptional patient where you might end up doing both. I'll come to Ashish Bhai. Ashish Bhai, we spoke about pleurodesis at length, but you must have done loads of pleurodesis in your career. What's the success rate and what factors do you feel determine whether your pleurodesis is going to be successful or not?
Yeah, that is very, very important because the family and the patient wants, if we are doing any procedure, what would be the success rate? Whether it is going to be successful, because we already tell the patients that the patient is in stage 4 where is not going to survive for a longer period of time. So, in my opinion and what we have seen in our day-to-day practice, that the apposition of both the visceral and the parietal pleura is of the foremost importance for the pleurodesis to get successful. And for that, the pleura has to be dry. If you cannot make your pleural cavity dry, it is going to fail. So the first thing is it has to be dry. Then second thing is if there is any suspicion of trapped lung, please do not attempt it. Please do not go in for this thing. And if you suspect or if you have seen in the medical thoracoscopy that the tumor load is very high, then your pleurodesis is not going to succeed because the mesothelial cells have been taken over by the cancerous cells. And the mesothelial cells are the only cells which show the inflammatory response, not the oncogenic cells. So it is going to fail. So in that case, the IPC would be a better choice rather than a pleurodesis. So that has to be kept into mind, these three conditions where the pleurodesis is going to succeed or fail. Depends. You have to be careful in selecting your patients.
Sure. So, Ashish Bhai, when you spoke about good contact between the visceral and parietal pleura, you obviously mean that we depend on the amount of fluid drained in a 24-hour period to determine that, whether there's good contact or not, isn't it? And your X-ray and your ultrasound. So that's one.
Yes.
The one question that I wanted to ask you was, you spoke about there being a lot of malignancy on the pleura. You determine that visually by seeing a lot of nodularity on the pleura. Is that what you mean when you say a lot of mesothelial cells?
Yes,
You sort of
larger, bigger nodules and the long-standing disease history.
Sure. But
That is,
you would still give pleurodesis a shot there, won't you? I mean, you would probably try a pleurodesis, and if that failed, you run the risk of there being some adhesions when you're trying to put your IPC in. But that would be the next step after, isn't it, when you're doing it?
Yes.
I can see Devi's hand. Devi, you had a comment.
And another case in In cases of loculated pleural effusion, pleurodesis should not be.
Yeah. Yeah.
Yes.
Absolutely. Let me come to the next question. So I think we have discussed all this actually, but very, very briefly. Vishwesh, I'll ask you something similar to what we asked Pawan a little while ago. You're doing a thoracoscopy, you've aspirated fluid, the lung is not coming up. What are the things you think of and what is it that you do? Briefly.
So we are basically dealing with a condition of a trapped lung. So trapped lung, the first important thing is you rule out a central airway obstruction, which is causing the trapped lung. So you can do if a patient is under GA or if patient is cooperative, do a bronchoscopy in the same setting to see whether you have some endobronchial lesion or not. And the second important reason could be like dense pleural involvement, dense visceral pleural involvement by the tumor. So that is an extrinsic, not related to the endobronchial thing. So in such cases, the only thing that can be beneficial is you put an indwelling pleural catheter on table and then come out, so that
Sure.
it can cause an autopleurodesis as well. So apart from that, there are either it should be endobronchial or it should be a visceral involvement of the malignancy. So
Sure.
in either cases, you can put an indwelling pleural catheter and come out. That is the most safest option you have
Sure.
when you are dealing with a trap lung.
Yeah, grand. Absolutely perfect. There's nothing to add. So I'll quickly go to Bala. I've got about 10 minutes to finish off. So brief answers to all my faculty. So Bala, give us a practical tip. You doing a pleurodesis, you spoke about two different agents, talc, betadine. What are the things that you think of when you're actually doing the procedure? What are the things that you need to tick off to make sure that your procedure is successful?
I think Vishwas has elaborated this in his talk. So usually the most commonest complications what we get with the talc or betadine is the pain. Usually that's the main commonest problem we get. So usually what I do, if I'm doing a thoracoscopy and if I feel that I should do a pleurodesis on table, the way go is like straight away do a talc pudraj. Because anyway the patient is already have sedation and analgesia. So you will have a very good control and you will see all the deposition of the talc over the
Sure.
parietal surface rather than the visceral pleural surface. You will have a very good deposition of the talc over the parietal pleural surface. So that would be the first way to do it. And the second one, what I usually see is I'm more bothered about the pain and the hypoxia, what is going to come after the procedure. So because doing a talc slurry or a betadine slurry is very, very easy. It doesn't take much time. It doesn't need any.
Yep.
My only take on this is to get maximum beneficial to the patient so that he doesn't experience a major pain after the procedure. So because usually the pain doesn't start immediately. What I've seen is usually in malignant pleural effusion, the parietal pleura is deposited with the malignancy. But if you do a talc pleurodesis or a betadine pleurodesis in primary spontaneous pneumothorax or some other cases, so those are the cases which are very, very painful compared to the malignant pleural effusion where your pleura is almost normal. So those will cause severe inflammation and cause more pain compared to malignant pleural effusion, talc pleural talc slurry or betadine pleurodesis. So that's what I look at it. Other than that, it's obviously a straightforward procedure to be done.
Sure. So how much of, so 4 gram of talc, how much of saline and how much of lignocaine do you normally use, Bala, for a slurry?
Slurry, this is what I do. So I make it a 100 ml solution. So total is a 100 ml solution. You have 4 gram talc
Sure.
water. So you make up to a 100 ml solution. So usually what I do, I take a 10 ml of 10 to 20 ml of 1%, 2% xylocaine. So the 10 ml of 2% xylocaine and the rest of all is the saline. So
Yeah.
you mix the talc and make it a slurry with 20, 50 cc syringes. You just push it 20, 50 cc syringes and clamp it for 3 to 4 hours. And what I do is to change the position every half an hour, 1 hour, so that it's just theoretical, so that the talc gets deposited all over the parietal pleural surface. But after 3 hours, 4 hours, you just declamp and see.
Yeah, grand. Yeah, that's beautifully explained. Wonderful. Let me come to Devi. So Devi, slurry versus pudraj. We've heard a lot about this, But what is your experience? What do you normally do? And do you think there's a greater complications in one way of putting the talc in versus the other? Do you think they're very similar?
So, I have much more experience with slurry because we have been doing it for a longer period of time. It can be done at the bedside, even in a frail patient. You don't need many instruments or much expertise. And in my support, most recent studies have found that both are equally efficacious. The most recent one, as Dr. Vishwas has already discussed about, is the TAPS trial, where at 90 days, the pleurodesis failure was assessed, and it was same in both the groups.
Sure.
And the largest trial we have is by Dressler et al., who have seen the success at the end of 1 month, and they have also found that both the groups are similar. However, there are some studies which show that talc pudraj is slightly more efficacious. However, the rate of complications are also more. In the
Sure.
few cases we have done the talc pudraj, we haven't seen much complications, and I think they have benefited early in the as the number of hospital stay has decreased. The radiological improvement was much more in the pudraj group, in my
Sure.
experience.
So I would agree with you, Devi. I think in my experience, even though the studies don't agree, it's very difficult to stratify patients into groups when you're comparing talc slurry with talc pudraj, and you would think that if you're draining all the fluid, if you're spraying the talc powder on the pleural surface in a uniform manner, the success would be greater as compared to a slurry. So I think our message from this platform is, if you have the option, you're probably better off doing a pudraj as compared to doing a slurry. Quick questions now, and maybe brief answers. I'll come to Dr. Ashish Tandon. Ashish bhai, thoracoscopy in someone who's already had talc in that space. So you're trying to do a thoracoscopy in someone who's had either a pudraj or a slurry before, because you still don't have the diagnosis. Is that challenging? Is that difficult? Have you done it? What challenges would you encounter?
If you are novice, please don't perform it. Please do not perform it, because there are so many adhesions, so much inflammation, fibrosis, which is going on. Please do not do it. This is the domain of the surgeon. To please hand over to your surgeon. Have confidence in him. He will put you to the diagnosis. So we don't attempt these situations where the slurry has already been put in, and it has failed, and again you try to do a medical thoracoscopy. It will sometimes badly fail. There will be a lot of complications, bleeding or pneumothorax. There will be high chance. So in my opinion, you should have confidence in your surgeon at that point of time. As a novice, do not attempt it.
I would go a little further than that, Ashish bhai. I would actually say that if you got slurry in that space, if you tried doing a thoracoscopy before, and if you've not managed, even for a reasonably experienced operator to try and get into that space and do a thoracoscopy and a pudraj again, is probably a bravado without intellect, I think, in my book. So I probably would, the message should be that we avoid doing a procedure like this, as you rightly said. Two interesting questions. I'll pose one to Bala quickly, and then I'll go to Pawan. Bala, we've often encountered these patients where you've put the talc slurry in, the fluid keeps draining, you keep finding there's a bit of residual effusion that's left behind. Would you do a pleurodesis twice over? And if you do a pleurodesis twice over, would you put in a different agent? Would you put in the same agent? Or do you think it's not really worthwhile trying to repeat a pleurodesis in these individuals?
This would be the best case for IPC, I think.
Yeah.
Just put in IPC and just leave it for some time. You will get a pleurodesis. So
yeah.
Vishwas has pointed regarding the combination of procedures and the efficacy of combined procedures, where he has said put an IPC and so that your efficacy increases. So this is a perfect case if your talc slurry is failed. If there's no need of to diagnose anything, just put an IPC and just wait for some time. You will have a very good pleurodesis. Only thing, there should not be a trapped lung or anything behind, so that the lung doesn't expand. Even though in trapped lung you can get pleurodesis, but the only thing, it takes a longer time.
Yeah. Yeah, absolutely, Bala. The only thing is that Najib's paper and the other paper that Vishwesh mentioned, it's actually the other way around. So you put the IPC in and then you put the slurry in through the IPC rather than having the slurry first and having a lot of adhesions and then having to put the IPC in, which has some amount of risk, I would guess, in putting the IPC in. But I guess it's less risky as compared to trying to do a thoracoscopy there. That's for sure. Um, I'll come to you, Pawan.
Yes.
Complications. So you're doing a thoracoscopy in someone with a malignant pleural effusion. Again, we've done this, but a quick laundry list. Major complications that people on this platform need to look out for, think about, and what do you do if you face a complication like that?
Right. So if you are well prepared and if you are functioning within your skill set, complications are very uncommon. The commonest thing which we encounter is the pain, and you want your patient while pinching the pleura, you may feel little pain and give a good sedation for that situation. If you are biopsying, most of the times these lesions are vascular, so chances of bleeding are there. Major bleeding is very less, encountered in less than 2% cases. If there is bleeding, then I have a protocol that you need to be prepared for the tamponade effect. Can be external tamponade with the fingers on the rib, as well as use a cotton pellet or a gauze pellet and just press it on the bleeding surface. You can use your cautery or APC for the control of the bleeding, and most of times the bleeding is controlled. Biopsy on the rib, not on the intercostal spaces, what Dr. Bala has also pointed out, that it will prevent the bleeding for sure. When you are doing deeper biopsies, the chances of bleeding are more during that situation. So be prepared to manage it. Apart from that, you avoid trauma to the surrounding structures. Like if when you're putting a trocar, when you're inserting the forceps, and if the patient is breathing or coughing in between, the lung may come near the forceps. So do not open the forceps blindly. Just inspect reach to the parietal pleura, identify the lesion, then only open the forceps. And when the lung is down, try to do a biopsy during that time. So it will avoid trauma, it will avoid the bleeding. Apart from that, post-procedures of fever, post-fluoridesis fever and pain is expected, and you use the adequate analgesia, and NSAIDs are equally effective even in fluoridesis situation. Getting in absolutely, if you have a sterile precautions followed, the chances of infection are extremely less when you are doing a sterile procedure in an endoscopy unit. And apart from that, the tract seeding has been another complication which has been reported in the literature. However, like once you diagnose the case, you subject them to treatment, so chances of having a tract seeding is less. So you may, because of pain, there might be some hypotension, some cardiac arrhythmias, but these are all reversible and can be managed easily. The mortality is extremely less with a medical thoracoscopy for sure.
Yeah. So very important messages, Pawan. The fact that it's very safe, the fact that the most important risk is that of bleeding. However, that's also less than 2% of cases. And if there's bleeding and if you're prepared, you can still control the bleeding very effectively. And I think the questions about pain, etc., are more about preparation, more about pre-medication, making sure that you give an intercostal nerve block to try and make sure that the pain is minimized. So all of these factors can minimize the pain that is associated with it. So there's a few interesting questions, Vishwesh. So I'll come to a question for you first, and then we'll do a quick rapid fire of questions in the question box. The audience has poured in lots of questions. So when would you involve a surgeon, Vishwesh? When do you sort of seek out your thoracic surgeon and say, hey, I put my hands up, please come and help me?
So whenever we see vascularized adhesions, or let's say that before you do a thoracoscopy, if you have a loculated pleural effusion with a thick pleural rim, where you will feel like if you go with a thoracoscopy, you will do a half-hearted attempt and come back, then always we give such patients for thoracic surgeons. Then whenever we see a case of a frank hydropneumothorax with pleural adhesions, we don't intervene. And sometimes you can make the extent of your CT may be undervalue the adhesions, but your ultrasound is a very good device to pick up the adhesions. If you see a lot of adhesions, trap lung, a possibility of trap lung, then we straight away go ahead giving to the surgeon. And while doing the procedure also, if you feel that your adhesions are very vascularized, then never attempt to do any sort of a mechanical adhesionolysis. You better call off your surgeon. So these are the indications where we generally don't go ahead with the medical thoracoscopy.
Yeah. So very good messages, Vishwesh. You come at a center which has got a very large patient volume. You are people who are very accomplished in doing the procedures that you do. But in spite of that, you make sure that there's a thoracic surgeon who is there in the background to support you if required. And that is something that people need to ensure when they do these procedures in smaller centers where thoracic surgeons might not be as easily accessible as they are to a lot of us who are on this platform today. So make sure that you have a backup plan. Don't start making up your backup plan in the middle of doing a procedure when you face a complication. There's something important for all of us to remember. Quick question. So there's a question in the question box which talks about a doxycycline capsule and how it can be used for pleurodesis. I think what Vishwesh meant was the liquid doxycycline or tetracycline, which is now available rarely. And the capsules that we have today, or the preparations that we have in this country today, to the best of my knowledge, you cannot use those for pleurodesis. So that's an important thought. Don't look for doxycycline capsules or any other capsule for that matter, and take the powder out and use it for pleurodesis. How much of lignocaine? I think we have answered that question. The fact that it's 10 to 20 ml, as Bala said, and you want to use it plenty because you want to ensure that the pain is minimized as far as possible. There's this question, how can an air leak be sterile when outside air is going in? Let me ask Bala to answer that question. Bala, so question is, there's air going in. How do we call the space sterile?
Usually the air doesn't go in
Yeah,
because
sure. Yeah,
you go connected to an one-way. So
correct.
basically, you have an underwater seal. The air doesn't go in. Obviously, it is not so common usually in bronchopleural fistula. Most of them are infected, but still you have good number of cases where there is a BPF without there is not significant amount of infection. So obviously the air doesn't enter inside the pleural cavity. That's the main reason we use an underwater seal.
Yeah. Yeah, and there's another question, and sort of Vishwesh, I'll give a quick answer and then you can add in. What about the suction bottle for the IPC? That's very expensive. So normally for the IPCs we use, most of our patients cannot afford a suction bottle. So we just connect it to a air seal bag. But anything different, Vishwesh? Do you manage to get your patients to buy the fancy suction bottle which sucks the water fluid in, or do you also attach it to a water seal drain?
So we generally don't ask them to buy the suction bottle. So on table, you can use a 50 ml syringe to aspirate and remove as much as you want. And next time when they come back to you after a week or so, again, we aspirate fully. So we don't waste the money on this suction bottle.
Okay. All right. I think we have run out of the questions. I think it's also getting quite late. It's 10:20. Very, very grateful to the audience who's actually kept logged in for the last 2 hours. We have been going on for a little less than 2 hours. Thank you to the wonderful faculty we have in front of us today. So Balaraju, Vishwesh, Pavan, Ashish Bhai, and Devi, you guys have been absolutely brilliant. A big thank you to the IAB team, and I can see Mehul. Hi, Mehul. Wonderful job. Great backup job. The way you've prepared for the meeting. A big thank you to Amita, whose brainchild this is, and she's put all of this together. And we go forward to the next module in a few days' time. A big thank you to the entire audience. And last but not the least, a big thank you to Sipla, who have provided a lot of support for us to do these meetings on a regular basis. So I bid you all good night, and thank you to the audience for having logged in and listened in.
Thank you. Thank you all.
Yes, sir.
Wonderful.
Thanks a lot.
Wonderful.
Nice, sir.
Thank you.
Thank you.
Thank you, sir.